Hello, everyone. Let me shut this door. It's a beautiful thing being able to do these lectures from home, but every once in a while you get a little view of my mess here. So my apologies for that. Also, the lighting in here is just horrible, so I look a little bit like a ghost. I don't really know how to help. Sorry about that. Anyway, moving right along. Okay. We're going to talk a little bit about substance abuse today and that section in the DSM because it can be a little confusing. Sometimes I obviously create my own PowerPoints for you all, but sometimes I find PowerPoints that are just so great that I use those. And it really is all the same information, so it's kind of like recreating the exact same thing, and no one really cares to do that. So, all right, that being said, I'm going to go ahead and share the PowerPoint with you. All right, so this is from the book Intervention, Treatment, and Recovery. So if you have a continued interest in maybe working with substance abuse, it might be helpful to you. So today we're going to understand the established diagnostic criteria for substance use disorders and describe treatment modalities and placement criteria within the continuum of care. And we're going to talk about substance-related and addictive disorders in the DSM-5. There are 10 classes of substances listed in the DSM-5, and there's also addictive disorders. Gambling is listed as well. Substance-related disorders are divided into two groups. So substance use disorders, which was previously split into abuse or dependence. And so this involves impaired control, social impairment, risky use, and pharmacological criteria, and substance-induced disorders. So substance use disorders, which is using a drug and having some negative consequences, and then substance-induced disorders. So actually having another disorder like bipolar disorder or psychosis that's induced by the use of a substance. All right. So diagnostic criteria related to substance use disorders. There's a cluster of cognitive, behavioral, and psychological symptoms indicating that the individual continues using the substance despite significant substance-related problems. And here's Pat that wants to say hello. He says, say no to drugs. And he's a very cute boy, but he wants attention right now, so I apologize for that. So yeah, the substance abusers and people who are dependent on a substance will continue to use despite significant substance-related problems. And there's a pathological pattern of behaviors related to the use of the substance. So when they're on the substance, they're engaging in behavior that's not really working for them. And that could be in their personal life, that could be professionally, could be their health or legal issues. So there are 10 classes of substances, as previously mentioned: alcohol, caffeine, cannabis, hallucinogens, PCP, others, inhalants, opioids, sedatives, hypnotics, and anxiolytics, stimulants, tobacco, and other. And then we have gambling as an addictive behavior that can be really detrimental to the lives of people who can't stop gambling. Substance use disorder criteria in the DSM, it includes using larger amounts. So substance use disorder is our addiction or dependence, so I want to point that out. Using larger amounts or for a longer time than intended, persistent desire or unsuccessful attempts to cut down or control use, a great deal of time is spent obtaining, using, or recovering, craving or a strong desire or urge to use, failure to fulfill major roles at work, school, or home, and persistent social or interpersonal problems caused by the substance use. Important social, occupational, or recreational activities are given up or reduced. Use in physically hazardous situations. Use despite physical or psychological problems caused by use. Tolerance to the substance. Withdrawal, not documented after repeated use of PCP, inhalants, or hallucinogens. So those are all the criteria that the person has to meet. This, of course, can be considered mild, moderate, or severe, and the severity depends on the number of symptom criteria experienced. So mild is 2 to 3 symptoms, moderate would be 4 to 5 symptoms, and severe would be 6 or more. So this is obviously happening on a continuum. And that really, that's a change from the DSM-4 that really accounts for the variability in some of these substance use disorders that you might see. Obviously a functioning alcoholic could maybe continue on at the moderate level for many, many years before they start having the severe symptoms. We know that the disease is progressive, but there's a lot of variation with people with regard to when or how severe it might become for them. But we would want to look at that criteria and determine how severe it is. So substance-induced disorders. So remember, these are disorders that happen because of the substance use. Are intoxication. So obviously when someone's, inebriated by the substance, withdrawal, when someone's coming off the substance, psychotic disorders. So people can become out of touch with reality when using a certain substance. Bipolar disorder can be induced. Depressive disorder. We know that, drugs and alcohol have a lot of negative effects on the body and particularly with mood. Anxiety disorder, sleep disorder, delirium, neurocognitive disorders, and sexual dysfunction. So we're going to describe a variety of helping strategies for reducing the negative effects of substance use, abuse, and dependence. And we want to tailor helping strategies and treatment modalities to the client's stage of dependence, change, or recovery. So let's look at the stages of change by Prochaska and DiClemente. So people start at the pre-contemplation stage. They're at this stage, like basically in denial. They have been maybe told that they need help or that they need to change some of their behaviors, but they're ignoring it. But it's kind of planted, the seed is planted. Then there's the contemplation stage. Okay, maybe this is a problem. Maybe I should think about changing. Maybe I should think about changing my behaviors. Then the contemplation stage moves towards determination. All right, I'm making a plan to change. I know I need to change. I'm going to go to rehab or get help on this date. Then there's action. That could be inpatient rehabilitation. That could be detox. That could be intensive outpatient or IOP. It could be just choosing to quit cold turkey and attending meetings. Whatever that means to the person. The action stage is when they've actually quit and they're working on it. Maintenance is when they're feeling pretty comfortable. They're feeling good about their recovery. They're feeling great. Some people call this the pink cloud stage. They feel like all their problems are gone. Their life is so much better. They're sleeping well. Their health is improved. Their relationships are improving. Everything is getting better. And this is when they might start to slip on some of their maintenance behaviors that have been keeping them sober, like attending meetings or even intensive outpatient or counseling. And people fall back into the relapse. So some people say that relapse is a stage of recovery, and sometimes people have to relapse a couple of times or maybe once to get a feel for what it's like to use again and then go back to being abstinent from the behavior or in the case of gambling or and sex. So sex is an addiction as well. There's even been talk of adding video games to the DSM or technology, but that hasn't made it. Anyway, sometimes relapse can be a part of the process, and then the cycle can kind of continue. The hope is that the person can become, clean and abstinent and in recovery for the rest of their life, if it's severe enough to warrant that. All right, so we have Prochaska and DiClemente's stages of change wheel. And the stages describe a person's motivational readiness or progress toward modifying the problem behavior. We talked about, pre-contemplation, not considering quitting. This is the denial stage again. The contemplation ambivalent stage, seriously considering quitting in the next 6 months, but not really sure if they're committed to that. They're kind of ambivalent. All right, preparation, readiness increases. They're planning to quit in the next 30 days. Change is underway in the action stage. They're, like I said, attending meetings. They're quitting. They're detoxed. They're maybe in the pink cloud. Maintenance is when, you know, they've quit for more than 6 months, and maybe they're still attending meetings or doing what they need to do to stay sober. And some people can take the stable change route and stay that way. And then, as we mentioned before, sometimes people do relapse. But you don't have to panic at this stage. It's possible to get back on track and get back in recovery, and to repeat these steps until you get to the stable, sober state. And usually after people relapse, it's a very rapid reentry to change. They know their life is better. They don't really want to live the way that they were living before. And so it's typically a quick turnaround to get back into treatment. And this is the stages of change distribution. So 40% of people are in pre-contemplation, 40% are in contemplation, 20% in preparation. Okay. So we're also going to provide treatment services that are appropriate to the client's personal and cultural identity and language. So of course, we always want to be culturally competent when we're considering the needs of clients. So culturally appropriate treatment for substance abuse may be viewed on a continuum. Cultural factors include heritage, history, and experience, beliefs, traditions, values, and customs. Cultural competence may be viewed on a continuum. So we want cultural sensitivity, cultural competence, and cultural proficiency. We'll adapt our practice to the range of treatment settings and modalities. Okay, so this brings up this visual here really brings up the fact that most people who are struggling with a substance use disorder are typically struggling with comorbid disorders. So other mental health issues need to be treated and managed during recovery, if there's any hope of the person staying sober. And often people are self-medicating with alcohol or drugs for a mental health issue that has not been addressed. So we want to make sure that you are addressing all of those things. And then it talks about level of care. So if someone comes to you and they're on the low level of care, maybe you can handle it in private practice with additional resources like sending them to AA meetings, or even, an outpatient group or something. But as you move along, you may need to refer them to a higher level of care. Because you don't have the capacity in an outpatient center to detox or provide them with medical care that they may very much need if they are withdrawing from substance. So the higher the level of care, the more you want to make sure that the person is getting what they need in terms of what the facilities can provide. Be familiar with medical and pharmacological resources in the treatment of substance use disorders. There are a variety of medications, and so if you look at this link here, there are a lot of medications and a searchable database online to let you know kind of what someone might be taking to help them manage their substance use. And you're going to want to try to understand the variety of insurance and health maintenance options available. And the importance of helping clients access those benefits. Recognize that crisis may indicate an underlying substance use disorder and may be a window of opportunity for change. So if someone is in a crisis mode, sorry, got distracted for a second there. So if someone's in a crisis mode, it might be a really good opportunity to help get them into treatment. So brief interventions are, short, problem-specific approaches used from risk to dependence and help clients reduce or stop abuse. Knowledge and skills for brief interventions, overall attitude of understanding and acceptance. So we want to provide that for every client all the time anyway, right? Counseling skills such as active listening and helping clients explore and resolve ambivalence. So we can try and help them understand where that ambivalence is coming from and work through it. We focus on immediate goals and working knowledge of the stages of change models. We might let them know that they could be in that stage of pre-contemplation. There are 3 steps in active listening. Listen to what the client says. Simple enough. We can all do that. Form a reflective statement to reflect your understanding. Repeat in your own words what the client said. You will learn this more in skills class. So if you have taken it, you know what I'm talking about. If you have not, you will. And test the accuracy of your reflective statement. Watch, listen, and or ask the client to verify the accuracy of the content, feeling, and or meaning of the statement. You need to understand the need for and use of methods for measuring treatment outcomes. Effective evidence-based substance abuse services. So to be ethical clinicians, we always need to be following effective evidence-based practices. We need to know when we've hit our limit and we need to refer. If you're working in a substance abuse or a substance use facility or rehabilitation facility, you will learn so much about how to treat substance abuse. If you don't know what you're doing, it's probably best to refer, especially if someone needs a higher level of care, because substance use disorders are very difficult to treat, and it requires a high level of commitment, both on the part of the counselor and the client. So these evidence-based substance abuse services are, demonstrable positive outcomes in terms of lowering recidivism, increasing victim satisfaction, or decreasing expenditures. And it's critical to improving outcomes, maximizing investment, and building support for further expansion of services. Okay, so if you want to take a look, these are some evidence-based treatment approaches. The Assertive Community Treatment, ACT, Evidence-Based Practices Kit can be a really good place to start. Of course, they've referenced the DSM-5 and SAMHSA's National Registry of Evidence-Based Programs and Practices can be a really good resource as well. And if you want to take a look at some videos and webcasts, there's Addiction by Prescription and Co-Occurring Disorders. We talked a lot about comorbidity and how important it is to treat both the substance use disorder and the comorbid issues that could be getting in the way of recovery. And there's a video on methadonia, which I'm guessing is about the opioid crisis. And you can look at some exercises and activities at the following link. That's all I have for you today. Thank you so much for listening. Substance use disorders, it's a huge topic, so don't feel like you have to know everything right now. You would really need experience working in this field for a little while and probably specifically in substance rehabilitation facilities to really get a good handle on how to work with and treat people who are struggling with substance use disorders. So, all right, that's all I have for you today, and have a great day.